All right, good morning once again, everyone, and welcome to today's webinar on hearing loss and cognitive decline. So hopefully you're in the right place. Thank you for joining us today. These complimentary webinars are brought to you through a collaboration of sponsorship with O'Connor Mortuary, Care Choices Hospice and Palliative Services, Caring Companions at Home, and Chatterton and Associates, the wealth management team, as well as us here at Alzheimer's Orange County. My name is Melissa Klabe. I'm the Director of Education here at Alzheimer's Orange County, and I'll be your host today. Our sponsors are providing these webinars to you as a service to the community on topics beneficial for anyone who cares for or works with older adults. We hope you find today's presentation informative and useful. Dr. Rose is a full-time treatment and diagnostic audiologist at House Hearing Health Center, operated by House Ear Clinic. She specializes in evidence-based practice and person-centered care, delivering hearing aid, bone-anchored, and cochlear implant solutions at the world-renowned Ear Clinic. She received her joint doctorate in audiology from the University of California, San Diego and San Diego State University. So let's turn it over to Dr. Rose.
Hello, everyone, and welcome to the webinar. Today, I'm going to talk about hearing loss and cognitive decline. First of all, what is an audiologist? An audiologist is a healthcare professional. We're similar to other clinical doctors like an optometrist or a dentist. And our job is to evaluate, diagnose, treat, and manage hearing loss and all kinds of other disorders that fall in line with that same system, including tinnitus or ringing in the ears, balance disorders, and this is in all ages of patients. Audiology is a well-recognized and highly well-respected profession, and we actually got started after World War I when there was a lot of veterans who had noise-induced hearing loss. And we just recently moved into the doctoral level beginning in 2012, moving from the master's to the doctorate. I'm going to be discussing effects of hearing loss. After that, we're going to be talking about cognitive decline, and then dementia, and then how all of these are sort of tied together and what the research is now showing. I hope that you guys can leave here today with the new impression that hearing care is actually cognitive care. So let's talk about the effects of hearing loss. Well, first of all, listening does take effort. We hear with our brains and not our ears. We actually use both ears to orient where sounds are coming from, to pick up the sounds that are happening around you. Those sound waves actually get converted into a neural impulse that gets carried up to the brain. And then your brain makes as much detail of this sound as possible to turn them into meaning. So your brain makes sense of the sounds in a normal system. How does it do this? It's hardwired to receive certain details of sound to make sense of it all. When it doesn't get those correct details, it has to work harder. So this is called listening effort. And when we have increased listening effort, we can have other symptoms like fatigue. There's a lot that goes on when we hear. First, we have to recognize what the sound is. Then we have to kind of orient ourselves on where that sound is coming from. We have to separate the important from unimportant. And then we have to focus on what we choose is important. When this doesn't work correctly, the brain does have to work harder, and then we have what we call increased listening effort. A person with normal hearing doesn't usually experience this type of fatigue. It's usually in an auditory system that's broken down where the brain has to process the information a little bit differently. So it has to use visual structures to take cues from lip reading along with context of speech and kind of paint a full picture. And of course, this takes longer. So someone who is hard of hearing and in a more complex listening environment is going to be a little bit behind compared to the normal hearers in the room. So this is kind of what happens when we have that process break down. So your brain receives less sound information when you have hearing loss. That makes it harder to recognize those sounds. When you're having to guess what people are saying, it forces you to concentrate even harder. And the extra effort leaves less capacity for remembering those conversations. And then you feel more tired after those situations. And then you're tempted to just withdraw from social interaction. Those of you who are listening probably have some older family members that may be exhibiting a whole array of different points in this sort of cycle that happens when we have age-related hearing loss. You might notice that some of your family members or friends who are older might just smile and nod and kind of pretend like they know what's going on, or they're just looking very confused and like it's a lot of effort for them to get your conversation, but they're still wanting to participate and they still want to know what that conversation is. It's really important to, slow down the group when you're aware that you have an older family member with hearing loss and kind of reiterate what's being said and make every effort to include them in that social situation. Next, we're going to talk about, what are the common signs of hearing difficulty? Well, people seem to mumble. This is like the #1 complaint with patients who come to clinic who are getting their, first hearing test after age 65. It's not my hearing. People are just mumbling. Or you might have a spouse who's complaining that you mumble. It's also hard to follow a conversation in more complex environments like meetings, noisy restaurants, or like maybe an outdoor situation with multiple talkers. And then you tend to limit those social activities. Maybe Uncle Joe doesn't really want to come to those family barbecues anymore because it's just too difficult to hear communicate, or maybe because they're just too tired. Okay, so now that we've talked about some of the first signs of struggling to hear with hearing loss, the other thing I want to talk about is cognitive decline. But before we end up experiencing cognitive decline, there's sort of this intermediate stage. We call it mild cognitive impairment, or MCI for short. This is the in-between stage of cognitive decline with normal aging and then the more serious decline of dementia. So this can involve problems with memory, language, thinking, and judgment that are greater than just the normal age-related changes. So I'm not saying you have mild cognitive impairment if you can't find your keys. So this is beyond that, but not quite to the dementia definition. So that brings me to, well, what is dementia? Dementia is actually really common. There's more than 3 million US cases per year. And there's treatment, which can help, but it can't be cured. It is chronic, meaning that it can last for years or be lifelong. It does require a medical diagnosis with either lab tests or imaging, which is often required. I also want to preface that I am not a neuroscientist. I do not have a degree in brain science or anything like that, but I deal with the older population, so I see a lot of patients who have dementia or early signs of dementia, and oftentimes audiologists are the first ones to make that referral to go back to see primary care for your mini mental state exam, which is like a little screening test for dementia. It's not a specific disease. A lot of people are under the impression that dementia is just one disease, but actually it's a group of conditions that have impairment of at least 2 brain functions like memory loss and judgment. So it's not just judgment. And some of the symptoms include, forgetfulness, limited social skills, thinking abilities that are really impaired, and it has to be to the point where it affects daily functioning. Medications and therapies may help manage some of these symptoms, but some causes are reversible, and we will get to that in just a moment. So now that we've talked about dementia, what is the role of the audiologist and cognitive decline in general? So when people come and see the audiologist, it's because they're not hearing well, and then they're not able to communicate very easily. And we know that communication difficulties is one of the earliest signs of dementia. So as an audiologist, I'm responsible for making a really timely and appropriate referral. And when we end up referring a patient who is actually diagnosed, that means that they're treated. So that can actually improve long-term outcomes, provide earlier diagnosis, and help to manage their cognitive decline. Next, we're going to talk about some statistics on hearing loss and dementia. So hearing loss is actually the 3rd most common health problem in the United States, next to arthritis and heart disease. A lot of people don't know that, But actually, 1 in 3 people over 60 years old have hearing loss. And for you baby boomers out there, 1 in 6 of you have hearing loss. And that's from all that good rock and roll, right? Very few people have no cognitive decline with age. So I just want everyone to know that cognitive decline is sort of a normal part of aging. And in 2010, 4.7 million people in the US over the age of 65 had the most common form of dementia, which is Alzheimer's disease. In 2016, this number grew from 4.7 to 5.4 million. And by 2050, this is going to be up to 13.8 million Americans that are going to be expected to have Alzheimer's. There's going to be a large overlap of older adults that have both hearing loss and cognitive decline. Next, we're going to talk about the different types of dementia. So I have just a few facts about each kind that I was able to find. The first one is Alzheimer's. Then we're going to talk about dementia with Lewy bodies, vascular dementia, frontotemporal dementia, Parkinson's disease, Huntington's dementia, traumatic brain injury, Wernicke-Korsakoff syndrome, mixed dementia, and postoperative cognitive dysfunction, or POCD. There was a study by Lenga et al. In 2017 that found that the number of new cases of dementia in adults 65 and over in the US fell by 24% in a 12-year period from 2000 to 2012. This might be due in part to a higher education level, better access to healthcare, and improvements in cardiovascular treatments. Now we're going to talk about Alzheimer's disease. This is the most common form of dementia, like I mentioned earlier. It's 2/3 of all cases. It's caused by plaques and tangles that disrupt normal nerve cell function in the brain. So these are actually little forms of proteins. The first symptom is short-term memory loss, but we also have other symptoms like it's hard to learn new information. They might have problems thinking or organizing thoughts, also poor judgment or confusion, also difficulty speaking, and like personality and behavioral changes. A lot of this kind of sounds like a stroke in some respects. But these changes that occur from Alzheimer's disease may actually happen years before any symptoms appear. I think I read it was like on average up to 10 years before the symptoms might appear. So that is really interesting. Unfortunately, the average life expectancy after someone's diagnosed with this type of dementia is 8 to 12 years. The next one is a little bit less prevalent, dementia with Lewy bodies. 20% of all dementia cases, this is the second most known type. This is due to an abnormal protein structure called Lewy bodies, which occur in the brain, causing brain cells to actually die. It can develop after many years of Parkinson's disease, which I didn't know before researching dementia. There's also a Parkinson's disease dementia, so we will talk about that next. This one has a bit more alarming symptoms, so vivid, complex visual hallucinations, fluctuating alertness and motor symptoms of Parkinson's, so maybe like an unsteady gait, stiffness, flexed posture. People with dementia of Lewy bodies are at an increased risk for falls because of this motor cortex component. The average life expectancy is about 7 years after the symptoms appear. Another type of dementia we're talking about today is vascular dementia. This can be caused by cerebrovascular problems like several small little strokes or one large stroke. The next one we're going to talk about is frontotemporal dementia. This is about 10 to 15% of all dementia cases. It's a group of neurodegenerative disorders that affect the front and temporal lobes of the brain. So this is like the planning area of the brain. Typically affects younger people, about 45 to 60 years old. And this is a specific protein that we know is called a tau protein. It creates tangles, much like the Alzheimer's disease, and that causes cell damage in the brain. Parkinson's disease. So this is also a neurological disorder that affects the brain, spinal cord, and nerves. It destroys nerve cells that make dopamine. So the cells are not able to communicate messages in the brain. We also see brain changes that are caused by abnormal deposits of alpha-synuclein protein called Lewy Bodies. So there's a little bit of overlap here between the different proteins that are happening and where they go wrong in the structures of the brain. The symptoms begin with movement issues like a resting tremor, shuffling gait, or a stooped posture. And this may progress to memory loss or the inability to pay attention and make sound judgments. It develops gradually. It starts after age 50 and it affects more men than women, which I found to be interesting. The next one is called Huntington's Dementia, also known as Huntington's chorea. This is actually a hereditary progressive brain disorder affected or caused by a defective gene. So it might be familial. It causes changes in the central area of the brain, so it also affects motor cortex, so affecting movement, mood, and thinking skills. And this one actually affects people very, very young. So they develop the symptoms between 30 and 50 years old. And unfortunately, the average life expectancy for someone who gets diagnosed with the Huntington's is only about 15 years after diagnosis. Traumatic brain injury. So I was unaware when I started this research that traumatic brain injury could be considered a type of dementia. But again, it only needs to have two of those areas affected, either judgment or memory. So this one is caused by impact to the head, which disrupts normal brain function, usually caused by a fall or car accident, something that's really, really impacting the skull. It may affect cognitive abilities, including learning and thinking skills. And we have classification. So there's mild traumatic brain injury, moderate TBI, or severe TBI. These symptoms may include unconsciousness, confusion and disorientation, difficulty remembering new information, headache, dizziness, blurry vision, nausea and vomiting, ringing in the ears or tinnitus, trouble speaking coherently, and changes in emotions and sleeping patterns. I saw a lot of TBIs when I did my fourth-year doctoral program at the VA hospitals in San Diego. And we actually had some very interesting protocols, including balance protocols to evaluate the vestibular system after a TBI. And we had to be very, very careful with these patients because they were very photophobic and phonophobic, meaning sound and light sensitive. So we had to, prep clinic, turn down the lights, make sure that we were really just doing very small increments up in the level of the sound to find the softest sound that they could hear when we're doing the hearing tests. So, and a lot of times, you could see that emotional aspect. So changes in emotions. I had one lady who would just suddenly weep for no reason, not really know why she was weeping. And this was part of her traumatic brain injury that she had sustained in Iraq. The next one is the Wernicke-Korsakoff syndrome. There's two stages of this condition, and this one is actually caused by a vitamin B1 or thiamine deficiency, and it's associated with malnutrition and alcoholism. I was unaware that alcoholism could lead to a form of dementia, which I don't think that we talk about enough in this type of culture that we have in the United States. The treatment is medically monitored. So a person has to, stop drinking the alcohol, and that's obviously something that has to be medically monitored. And they also have to take a B1 supplement that will help resolve many of the symptoms except for memory loss, which is permanent. The next dementia is mixed dementia. So this means that there are symptoms and damages that are characteristic of more than one type of dementia, and they have to occur at the same time. The most common types that occur together are Alzheimer's, vascular dementia, and dementia with Lewy bodies. So all of those more common dementias. And this mixed dementia is actually more common than previously thought. We have posthumous exams that show that 45% of people with dementia have both Alzheimer's and vascular dementia. You guys are maybe seeing a little bit of a pattern here with the blood flow components. The average life expectancy for this mixed dementia is going to depend on the type of the dementias diagnosed. The last dementia we're going to talk about is postoperative cognitive dysfunction. Now, I always preface with this slide with the fact that you should not avoid a life-saving surgery because you're worried about developing this condition. You and your medical doctor will determine, if this is even a possibility. So, what is it? It's a decline in cognitive function that lasts for weeks, months, or may become permanent after a surgery. So people with undiagnosed dementia or like an MCI, a mild cognitive impairment, they are at the greatest risk for developing the postoperative cognitive dysfunction. It may cause impairment in memory, concentration, comprehension, or language ability. But really, there's no specific causes that we know of yet, but from the research that we do have, we know that it doesn't matter if it's a local or a general anesthesia, and also the length of the surgery is not a factor, which I thought it would have been, having to do with like blood flow. But apparently the type of surgery does impact it, and those who are having open heart surgery have a greater risk of developing this condition compared to other, longer and more complicated surgeries. People who experience this at their discharge from the surgery have an increased risk of dying within the first 3 months following the surgery. Now, I'm not saying that this is a causal thing, but it's definitely a correlational thing. So just something to be aware about if you have any family members who are getting out of surgery and just don't seem like the person that you remember, to bring this up. Okay. So next we're going to be talking about causes of hearing loss. So we talked about all the different types of dementia, mild cognitive impairment, what happens when hearing loss kind of breaks down and we don't have a normal hearing system anymore, and what that person goes through. So there are many different causes of hearing loss, the most common being age-related or presbycusis. This happens because of the way that our inner ear is formed. It's a little snail shape that has little sensory cells inside, and they're arranged from high pitch to low pitch in the center, like a little spiral. But it doesn't matter what sound we listen to, all sounds throughout our whole lives have to go from the high pitches to the low pitches to get to where they need to go. So those high pitches tend to wear down with time, age, and noise exposure. Even quiet tribes in Papua New Guinea that have no noise exposure, no industrial departments, just basically very, very low levels of noise throughout their whole life, still wind up with mild to moderate high frequency sensory neural hearing loss when they're like about 80. So it's just part of being a mammal. Another cause I just mentioned earlier was the noise-induced hearing loss. So that's the fancy term for that is called sociocusis. This is damage to hair cells and the cochlea. It can be sudden or gradual. So noise-induced hearing loss is a factor of two things. One is the level of the noise and the time or length of the exposure. And you can look up on OSHA website to see how many hours you can be around a certain level of sound before permanent damage might occur. And a majority of you have smartphones, so I encourage all of you to get on your app store and download a free sound level meter app. You can just type in sound level meter, hold your phone up to that noisy bar or concert and measure the sound and be responsible for your hearing. If it's over 85, my rule of thumb is to just put in earplugs or move away from the sound till it goes below 85. There's about 26 million Americans from ages 20 to 69 years old that have high frequency loss due to loud noise exposure, either at work or for recreational activities. The other cause of hearing loss I'm going to talk about today is congenital or genetic. This is usually due to a family history or predisposition. There are also non-familial genetic hearing losses that happen just from a spontaneous gene that just kind of went wrong during the embryonic development. There's a whole other presentation I could do just on the gene science behind hearing health. Anywho, the other cause of hearing loss is ototoxicity. So oto meaning ear, and then toxicity meaning toxic. This is drug related. It becomes a nerve hearing loss, or what we refer to as a sensory neural hearing loss, where it either degrades the hair cells themselves or it affects the nerve as it leaves the cochlea and goes up to the brain. Some ototoxic drugs are actually anti-cancer drugs like chemotherapy. Usually it's an IV chemo. Also radiation can affect the hair cells if it's to the head or neck, not usually if it's like to a lower limb. Also aspirin in high quantities, quinine, which if you drink a ton of gin and tonic, there's actually quinine in some tonic water, so you want to be careful about that. And then also certain antibiotics, so a lot of the mycin drugs, and also some of the cystic fibrosis drugs that are given can be ototoxic. We also know too that abuse of certain narcotics, like an Oxycontin, can definitely affect the hearing permanently. So another thing we're going to talk about are risk factors. So we know the different types of hearing loss. We know what happens when it goes wrong at the brain level, but who's at risk for this? So the first one I have on the slide today is smoking. So smokers have a 70% higher risk to have hearing loss than non-smokers. So all the more reason to put down the cigarettes. Diabetes. Hearing loss is twice as common versus non-diabetics. And pre-diabetics have about a 30% higher rate of hearing loss than those with normal blood sugar. Heart health is a huge one. So the inner ear really is very sensitive to blood flow. It needs a lot of blood flow through there to get the nutrients that it needs for those tiny little hair cells. So when that doesn't happen, they have a tendency to atrophy and then die. Studies show that inadequate blood flow and trauma to the blood vessels of the inner ear can also contribute to hearing loss. Hypertension. So there's a significant association between high blood pressure and untreated hearing loss. And this can be actually an accelerating factor of hearing loss in older adults. So next we're going to talk about the effects of untreated hearing loss. So for all of you who have parents who are kicking and screaming that they don't want to get hearing aids, this is what you need to pay attention to. Memory. So you're more likely to develop problems thinking and remembering versus adults with normal hearing. When you have a hearing system that's broken down, that forces your brain to develop too much energy to then process the sound. So you're paying so much attention to the incoming signal that you're not able to remember what was just said or what's being said currently because you're too busy figuring out what that signal was. Dementia, we're going to talk about that more. Falling. So this is kind of more in recent research in the last 5 to 10 years that people with mild hearing loss are 3 times more likely to have a history of falling. And for every 10 decibels more of hearing loss, this increases the chance of falling by 1.4 times. Mental health. This is a really big one. So tinnitus, adults that are over 50 that have untreated hearing loss are more likely to report depression, anxiety, anger and frustration, emotional instability and paranoia. They're obviously less likely to socialize more, versus people who wear their hearing aids. And we also find that the degree of depression or other mental health issue increases with the severity of the hearing loss. So the more hearing loss you have, the more of these things are going to impact your life. Tinnitus. So 90% of people with tinnitus, or some people say tinnitus. In the professional world, we say tinnitus, because if you see the way that that's spelled, it's not itis, and itis implies inflammation. So it's tinnitus, or ringing in the ears. This is a symptom of hearing loss. We think it's the brain searching for sound that it used to have. And when I did my 4th year rotation at the VAs, that was the first line of treatment for tinnitus was amplification or just straight up hearing aids. And this would help about 80% of the time. And then we'd go on to other things, which is a whole other presentation. So the next evidence we're going to talk about is how hearing loss is linked to accelerated brain tissue loss. So Johns Hopkins and the National Institute on Aging put out this research in 2014. It was part of the longitudinal Baltimore study on aging, and they looked at about 120 participants. And it was basically looking at their fMRI images of their brain over a 10-year period. So the researcher, his name is Frank Lin, and his colleagues, they looked at those 126 people. 75 had normal hearing and 51 had at least mild hearing loss or worse. They found that there were faster rates of brain atrophy versus normal hearing group, and that the hearing impaired group lost more than 1 cubic centimeter of brain tissue each year versus the normal hearing group. There's significantly more shrinkage in the brain areas that are for processing sound and speech. And these areas play a role in memory and sensory integration. And these can also be shown to be involved with the early stages of mild cognitive impairment and then also Alzheimer's. Next, we're going to talk about hearing loss and incident dementia. So going back a little bit, in 2011, Franklin and colleagues looked at that same longitudinal Baltimore study on aging for people who were between 36 and 90 years old. All of them were dementia-free at the start of the 18-year study. They looked at the incident risk of dementia and found that it increased with the severity of the hearing loss. So compared to normal hearing, increased risk for dementia was 2 times for mild hearing loss, 3 times for moderate hearing loss, and 5 times for severe hearing loss. And that was for, all incident dementia or all cases of dementia. When we look at just the Alzheimer's disease risk, that actually increased by 1.2 times per 10 decibels of hearing loss. So they concluded that hearing loss is independently associated with incident all-cause dementia, and whether hearing loss is a marker for early stage dementia or is actually just a modifiable risk factor for dementia deserves further study. So, and I'll mention later again that in 2020, Frank Lin is going to come up with a separate treatment study to look at whether or not hearing aids can actually slow down or help attenuate some of this cognitive decline and maybe help stave off dementia. So that's been going on since 2011. Another study that came out more recently in 2015 by the Journal of the American Geriatric Society was self-reported hearing loss, hearing aids, and cognitive decline in elderly adults. This was a 25-year-long study. There were quite a number of participants, so 3,670 over age 65 in France. 137 reported major hearing loss, about 1,100 reported moderate hearing loss or difficulty in background noise, and then about 2,400 reported no hearing trouble. Looking at the results, the self-reported hearing loss group was significantly associated with greater cognitive decline during the 25 years. This was independent of age, sex, and education. So the people with hearing loss that did not use hearing aids had a steeper rate of cognitive decline. The people with hearing loss who did wear hearing aids had no difference in their cognitive decline compared to those with normal hearing. So their conclusion is self-reported hearing loss is associated with accelerated cognitive decline in older adults, and hearing aid use attenuates such decline. When this study came out, the hearing aid companies went nuts over this. They all started putting out these little brain posters and saying, eureka, we have it. But you have to keep in mind that this was not, a double-blind study. This was based on a survey, and so there was a lot of qualms in the audiology community with how much we really should be touting this information. But to me, all information is good information as long as the study was done properly, and nobody was discounting that this study wasn't done properly. It's just not the type of study that we usually would use in, a type 1 research evidence-based study. So, but it's just more to add to the plate. Another study that I want to talk about today is from 2015. This is the Atherosclerosis Risk in Communities study, and it's looking at the effectiveness of intervention with hearing aids. So this guy Deal and his colleagues addressed the hypothesis that maybe older people with hearing loss who use hearing aids have slower rates of cognitive decline versus the older age patients or persons with hearing loss who did not use hearing aids. And this was a 20-year study. So they found that older people with moderate to severe hearing loss, which is over 40 decibels, had poorer performance on memory tasks and global cognitive function versus those without hearing loss. The people with moderate to severe hearing loss showed decline on cognitive tasks over that 20-year period. And the greatest decline was actually seen in the group who did not wear hearing aids. Now, this researcher found that people with the same hearing loss who used hearing aids showed global cognitive decline, but only slightly greater than the decline in the normal hearing group. So overall, evidence does support that participating in cognitively stimulating environments as an intervention for the management of dementia. Hearing aids allow cognitive and interpersonal stimulation and engagement. And by decreasing that listening effort, the hearing aids allow people to feel less exhausted after socializing. That helps to dedicate them to have more energy for more engagement with family and friends. There's actually been more research in this area with cochlear implant patients, and I'm talking about elderly populations. So we do know that cochlear implantation can help those who are exhibiting beginning stages of dementia to help kind of stave that off further so that they can communicate and engage socially. But more research is needed to find out if hearing aid intervention is a viable protection against or decelerator for cognitive decline. We can't say definitely that hearing aids prevent, delay, or slow cognitive decline yet. We can say that a well-fitting hearing aid can allow people to cognitively engage, which help to prevent, delay, or slow cognitive decline. Okay, so next we're going to talk about basically some new and current hearing aid technology. So this has been, Telecoils have been around for, gosh, I don't know, 25 years. Basically, it's a little coil inside of the hearing aid, and it's a receiver. So it takes in information and then turns that into sound. It has to work with a particular audio system called a loop system. It's an electromagnetic field that gets propagated through this little coil that gets placed around a room. But the hearing aids need to have a T-coil in order to catch this sound from the loop, the copper loop. They also have to be activated. So someone can have a T-coil, but it may not be activated, and they just need to see the audiologist to do this. More and more churches around Irvine and also Orange County are getting looped. There are some movie theaters and also entertainment venues that are also looped. This is a very cheap technology. It has pretty good sound transmission. I would say that the direct Bluetooth options are a little bit better. So the newest products are now built-in rechargeable hearing aid batteries. So now you never have to change a battery, which can be, an issue for someone who has cognitive impairment or maybe some arthritis, and it's hard for them to physically change the battery. But now they can last anywhere from 18 to 36 hours on an overnight charge. And the life of the battery itself that's inside the hearing aid is about 4 years. And some are made for iPhone. So now we have all these hearing aids out there that can be a Bluetooth receiver for phone calls. So you can have the phone calls go into both ears. You can stream TV, music, TED Talks, audiobooks, anything you can think of that makes sound coming from your cell phone can now go into the ears. And there's no need for a necklace receiver or catcher for that kind of system like in the past. We also have most of these rechargeable made for iPhones do not have T-coils, but more and more of them are starting to have them now compared to when I made this just a year ago. There's also now more than just resound. There's several companies that now offer remote programming for my patients. So patients can send me a little notification through their iPhone. Hey, I'm not hearing so great at this Starbucks. Can you please help? And then I get a little pop-up on my screen, and then I go into their settings and tweak it, maybe increase the noise management, and then it pushes it back to the iPhone, and the iPhone puts it right into their hearing aids. So multiple trips back to the audiologist are no longer needed because we can do simple tunings from afar. There's also new bone conduction hearing aids that are totally non-invasive. There's one by a company called Medel called Adhere. It's fashioned onto the back of the ear against the mastoid bone with a little tiny sticker. And it kind of just snaps into the sticker, and then it vibrates the sound, skipping the outer and middle ear and going right to the inner ear for your conductive hearing loss patients. So that's all I had on the little bit of technology. So from here, as a patient watching this presentation, do you do nothing or do you go forward? A lot of times patients are kind of more accepting of the fact that there's a real cognitive component that is showing in the research, and they give up the cosmetic worry and also the stigma worry of having a hearing aid. I think that also millennials and younger generations, the Gen Xers, are kind of making it less stigma to have ear-worn type devices. And then right after I was done putting this whole presentation together, just middle of July, a little article came out that I picked up on. And it was showing that basically there were a couple groups, and this is done in the UK, couple groups, those with hearing loss that didn't wear hearing aids, and then those with hearing loss who did. They actually did some specific cognitive tests over a 2-year period, and it showed that those who were in the hearing aid group had performed better on tests of working memory and then also some attention tasks versus those who did not wear hearing aids. So for the sake of time, I'm going to let you guys read over this study if you'd like. I do have some qualms with this study. It is survey-based. It's not double-blind. It only has 2 tests total that they're looking at. And there's no real article. It was just a poster. It's too new. It may be not published yet, and it might just be a really quick release. But it was put out by the Science Daily report on that date. So if you want to pull it up on Google, you can certainly take a look for yourself. But again, we're waiting till 2020 when Franklin and colleagues from Johns Hopkins have a more legit study that are looking at treatment effects of hearing loss and cognitive decline using amplifiers and also hearing aids. And that concludes my presentation.
Wonderful. Well, I learned so much. Thank you. That was a wonderful presentation. If you guys have any questions for Dr. Rose, be sure to type them in. We're already getting some good questions in. We have about 10 minutes to answer. Before we begin the Q&A session, if we do run a few minutes past 12:30, you are welcome to remain online. But if you need to leave, you can. Just remember, if you want to earn that CE credit, you just have to be online for the 60 minutes. I want to take this time to thank our sponsors once more for making these presentations possible. We are so grateful to support from Chatterton and Associates, the wealth management team, O'Connor Mortuary, Care Choices Hospice and Palliative Services, and Caring Companions at Home. And I want to remind everyone also about next month's free webinar on the cultural diversity of grief and loss. That will be on a Tuesday again at 11:30 Pacific time. And Dr. Bill Hoy will be presenting. All right, so let's get to our good questions here. And the first one is, can you repeat that app that you mentioned for our phones for the sound, recording the sound level?
Sure, yes. It's called Sound Level Meter or something like that. I don't have an iPhone. Mine is just called Sound Meter on my Android, I believe. But there's going to be all kinds of apps. So you want to just choose one that's free, or if it has any association with OSHA, that's a good one.
Okay.
You might have to pay like $1 or $2 for that OSHA one, but that's a really good one.
All right, great. There was a comment about the smoking. Would you say that secondhand smoke is a cause for concern as well as if you're a smoker yourself?
I have not seen any specific research as to secondhand smoke affecting the hearing loss, but if it's having any kind of cardiovascular impact, then I would have to posit that that is a likely possibility.
All right, fair enough. Next question is, this may be kind of a case example, but should a person with a TBI and tinnitus, I just learned how to pronounce that, by the way, thank you, I was been saying tinnitus. So should a person with a TBI and tinnitus get a hearing test?
Absolutely. That should be part of the protocol when someone's diagnosed with TBI, and especially if they have ear ringing. Sometimes when we have transverse blows to the skull, you can actually have the middle ear bones break, and then that can be repaired through surgery. Sometimes if the skull itself has fractured, they can help the hearing that way, to help make sure that the sound is, transducing through the ear properly. But yes, that should be definitely a part of the protocol for any patient with a TBI, and regardless if they have ear ringing or not.
Okay, thank you. I had this question as well, but we got this question from a listener. How about the effects of wearing headphones, AirPods, things like that? Any bad effects?
Yes.
Any comments?
Yes. There are preliminary research to show, I believe it's 1 in 5 teens have some noise-induced hearing loss due to personal sound devices. So if you guys are parents and you've got children out there that are gaming or using headphones, you can purchase ones that are for children that have noise-limiting speakers so that they're not over dangerous listening levels. A lot of the times when we're having the kind that go in the ear and we're in a loud like lunch auditorium or something, we're cranking up that volume because the noise from the room is getting past those headphones. So then you have a need to crank up the sound. This is also common at gyms. And I will say that Zumba class, all those group classes, the spin classes, they are notorious for pumping volumes that are 95 decibels and above. So you definitely will have some ear ringing after that if you're not protecting your ears. So anytime you feel like putting your hands over your ears or backing away from the sound, that's your body telling you need earplugs.
Thank you so much for that. So on that ear ringing, if you do notice your ears ringing after you're in a loud setting or something like that, is that a precursor to like damage, would you say, or is that just kind of your body warning you?
That is a symptom of temporary threshold shift. So that's a symptom of temporary hearing loss. And over time, if you continuously expose yourself, and you will notice that ringing maybe is permanent, and also you would see on the audiogram a permanent threshold shift.
Wow.
So a permanent change in the hearing.
Okay. We have a question on what kind of training that general practitioners, physicians are given about hearing loss. Do you have any idea of what their training involves?
So when I did my second year at UC San Diego, we actually took a free clinic class where we were in the room or in the class with the primary care providers that were studying to be a primary care. I think that they were first and second years in med school. And they really don't get a whole lot. They get structure of the ear, and that's about it. All of this kind of cultural stuff, emotional stuff doesn't really come with that. They also don't know how to read audiograms. So my friend and I, a colleague, we actually had a little session with those students and taught them how to read an audiogram. Also, we talked about sudden hearing loss and how you shouldn't just give people allergy meds. You need to actually do a hearing test, and they possibly would need, high dose steroids to bring back the sudden hearing loss if it's at the nerve level. So if you know anyone that has a sudden hearing loss, you have about 30 days to get medication if it's a nerve loss to bring back the hearing. And if it's past that, they may not treat you and it may not come back.
Wow. Okay. I'm taking notes furiously. This is great information. Thank you. So let's see another question here. I feel like this is a pretty common question you probably get. Will cleaning your ears with Q-tips, let's say removing earwax, does that have any effect on hearing loss or damage?
Yeah, so if you read on the package of the Q-tips, it says do not put in ears, and there's a reason for that. We make wax on purpose. Our ears make wax because it is antimicrobial. It acts as a barrier to the eardrum so that little insects can't crawl past and get past the eardrum. And it helps as a lubricant to help keep our ear itch free. So wax is a good thing. It means you're a healthy human. We don't want to take out too much wax or you can wind up with a really itchy ear and other skin issues. And if you're physically putting that Q-tip in there, you could be impacting the wax. You might take it out and see wax on there and think you got all the wax, but actually I see it all the time where there's just a wall of wax that's causing a temporary conductive hearing loss. So actually it can make your hearing worse. If you lighten up on that Q-tip addiction, your little sensory cells won't think that you're a bug crawling through there, and you'll probably wind up with less wax over time.
Okay, good to know. How about Medicare? Are hearing aids covered by Medicare?
Hearing aids are right now, there is no coverage for them in that I can't bill Medicare for a hearing aid. They do have a new Plan F that allows you to go to sort of a like a discount type situation where you get just some hearing aids from a vendor. Can be an audiologist or a hearing instrument specialist, and there's a big difference there that we could give a whole other presentation on. And they get a few visits. It is not like a bundled boutique kind of service. So there's many different deliveries of hearing healthcare. You can have a retail setting where you go to like a Costco. You can have a medical setting where you come to like house, or you can have this third party distributor type setting where you're not going to get the type of care that you would probably get at A or B, but it's a really great option for people who can't afford the more boutique or retail type settings.
Gotcha. Okay, here's a question about the VA. So this person says, I have veterans who have tinnitus. They refuse to accept that they also have some hearing loss. They have free testing through the VA, but think tinnitus cannot be treated, and they do not want a hearing aid. What do you think the VA is telling these people?
Well, it's really well known among the veteran community that tinnitus is one of the most highly reimbursed conditions for compensation and pension exams. And there's no way to prove you don't have tinnitus. So a lot of them will go and just try to get, compensation and then not really opt for treatment. It's just kind of a misnomer that that they don't need hearing aids. I don't know why they think that. And it could be that, they have all these other confounding issues. We're working with patients who have PTSD. The last thing that they're maybe thinking of is that they need a hearing aid. But when it does get to that point where it's really, really severe, they usually will have to go through the whole protocol, and they will require them, if they're on the care side of things, not compensation, to get a hearing test and then be treated that way. When we would fit the hearing aids, and about 80% of the time it would work, the other 20% of the time we would turn on a masker, which is a special type of noise that plays through the hearing aid to give them a little more stimulation in the area where the tinnitus is happening in the brain. And then for those where that also was not enough, we would do cognitive behavioral therapy referral. So they would actually get CBT therapy in conjunction with the sound therapy, and that is the most gold standard form of treatment that we currently have. So they're in denial that they have a hearing loss. If they won't get tested, then they won't be labeled, and then they won't have to know that they need hearing aids. But yes, tinnitus is the brain searching for sound it used to have.
Great, thanks for that answer. So how about patients who have hearing aids but don't wear them consistently? How is their hearing affected?
So if we have inconsistent use of hearing aids, this is like taking half a dose of medicine. Okay, so hearing aids are like sound medicine for your brain. And after I tell patients about all these findings with the dementia and the untreated hearing loss, if you're only wearing your hearing aids out to a restaurant, that's untreated hearing loss the rest of the time, and we don't know what that's going to do to your brain. So you better just wear them from the time you wake up to the time you go to bed, no matter if there's anyone around to talk to you. So it's actually, a brain cognitive health thing. And also the brain will not acclimate to the hearing aids. It will never bond with the sound that comes out of a hearing aid and be able to do that orienting that we talked about early on in the session here. So the brain needs exposure. It needs practice to remember those sounds, where they go and what they mean. And if you don't wear them consistently, you will never get past that adjustment period. And if you really don't wear your hearing aids and they just are in the drawer hearing aids rather than in your ear hearing aids, you can actually exhibit symptoms of auditory deprivation. And auditory deprivation is where over a period of 10, 15, 20 years of non-use, even if your beeps, the level of detecting sound stays the same, the clarity for the word testing starts to go down. So I can crank up that volume above the softest beeps that you can hear, but when I say the word boat, you repeat back the word bat. So it actually can degrade the nerve transmission by not stimulating the nerve with a hearing aid over many years.
Wow. That's fascinating information. Probably have time for one more question here. I want to be respectful of everyone's time. With the remote programming you're able to do with certain hearing aids, has it shown any change in patient costs? How has it changed the availability of audiologists or practitioners? Has it improved, increased, or decreased costs? Can you speak to that?
So currently at the position that I'm at, we are a fully bundled center. So having that remote programming capability is only saving patient cost in terms of gas and time.
Mm.
In the future, there's going to be other types of delivery methods where maybe you get a pair of hearing aids in the mail, put them in your ears, turn on your iPhone, and someone programs them from your iPhone. And in that respect, yes, I think that the cost of the hearing aids are going to come way down. And in August 2020, we are going to have over-the-counter hearing aids. So you're going to see a huge reduction in cost for people who have mild or moderate hearing loss. The self-diagnosis factor is a very big issue in audiology for those at the moment, and the FDA is still figuring out all of those labeling issues right now.
Gotcha. Well, thank you so much again. This was a truly, truly informative presentation. I know I sure learned a lot. One person just said they found the app. It's called the NIOSH sound level meter. So I'm sure, like you said,
Yes,
there's a lot of apps out there.
That's a really good one. Get that
yeah,
one.
Everyone's homework is to download that. And thank you again, Dr. Rose. And
Sure.
thank you to everyone that attended. Hope to see you all again.
Have a good one. Bye-bye.
Bye-bye.